My goodness, what are we going to do now? And so here I'm going to show you a patient with very severe atopic dermatitis. He was 12 years old when he first came to see us, with several years of gradually worsening eczema. When he first presented to our clinics, he was erythrodermic from head to toe. This was in an era before we had access of a biologic therapy. So he was started on classic therapy of cyclosporine. We were able to achieve improvement, and then finally it came around the time where we were able to get therapy for him, Dupilumab. But as the cyclosporine was weaned off, one of the things that we noticed is his disease started to come back. And so as opposed to the 200 milligram weight-based every 2-week dosing, we had to increase that. And then a little thing called COVID hit. We lost follow-up with him, and he represented on Dupilumab at 300 milligrams every 2 weeks, literally erythrodermic again. So our hands are up in the air. My goodness, what are we going to do now? And so we needed to rescue him. He had intractable itch, was unable to sleep, was not going to school, to bring him back with therapy with cyclosporine. But obviously, we know cyclosporine is not a long-term therapy. And so we trialed to use methotrexate for a period of time. That wasn't able to keep things under control. Dupilumab was trialed again, and then ultimately it was not until getting a JAK inhibitor approved off-label at that time when we used this medication of upadacitinib. But as soon as we came off the Dupilumab, his eczema seemed to come back. And so it's really been only to this period of time where we've need to use dual therapy to bring this patient under control. And so occasionally in tertiary clinics, we will see profoundly refractory patients, and this is an example of one.